conduction starts from the
Yeah, proceed.
Okay, sir. So once the conduction starts from the SA node, it reaches the AV node through the internodal fibers. So what happens? This right atrium contracts, but there is no. So once the SA node contracts, this from the electrical stimulus from the SA node travels to the internodal fibers to the lower part of the right atrium till the AV node. And as soon as the right atria contracts, the left atria also contracts through this Bachmann's bundle. And from the AV node, these impulses will be traveling towards the ventricle through the bundle of His, and this, as the bundle of His divides, this electrical activity also transfers to the ventricle, both the ventricles, and the ventricle also contracts. So this is the electrical conductivity system of the heart, that is SA node, AV node, bundle of His, right and left bundle, and Purkinje fibers. So regarding the impulses, the SA node is capable of producing impulses from 60 to 80 per minute. So this specialized structures in the SA node, it contracts at a rate of 60 to 80 per minute. And AV node, it contracts at a rate of 40 to 60 per minute. So this is 80 to 60, this is 40 to 60. Bundle of His is also 40 to 60, and right bundle and left bundle, it is 15 to 40 per minute. So this is the rate at which the electrical conductivity travels. The importance of this is, once the SA node fails to contract, what happens is AV nodes start contracting. So we'll be discussing about sinus bradycardia or supraventricular tachycardia, supraventricular bradycardia and all. For this is very, very important. So what happens is, once the SA node fails to contract, AV node will take its function. So what happens? The pulse will be less, because the conduction system, the conducting the range, the rhythm of the heartbeat will be changed as the number of impulses is reduced from the AV node. So this is regarding the conduction system of the heart, and the ECG is explained in the terms of conduction system of the heart. So I think it is clear.
Please go ahead. You have unmuted. Mute it. Unmute it. Unmute it. Sorry.
Okay, okay, sir.
Yeah, now it's okay. Clear. Please go ahead.
So this is not moving.
Disconnected. Now you are not seeing your screen. Yeah, sharing. Okay, go to the next. Now it is visible borders of heart. Now you go to the sharing mode. Sorry, presentation mode. I think. Presentation mode. Yeah. Now we start. Yeah. Okay. Yeah. Now it is okay. Please start.
So this is regarding the depolarization and repolarization of the heart. This depolarization and repolarization is very, very important as far as the ECG waves are concerned. So when explaining about the waves, we'll be saying it is due to repolarization, it is due to depolarization, like that. So this slide explains about the depolarization and repolarization of the heart. So this is a graph. The x-axis represents the time and y-axis represents the voltage. So what happens is when there is a impulse which is given to the cardiac muscle, so what happens is it starts contracting. It starts contracting. So during contraction, what happens? We all know that sodium and potassium are the ions which is responsible for the depolarization and repolarization of the muscles. So in case of heart is also, it is the same thing. So what happens is during depolarization, sodium is the ion which is present outside in the extracellular membrane, and potassium is produced is seen inside the cell. So what happens is during depolarization, this sodium channels open and sodium goes towards the cell, cardiac cell. And what happens is potassium ions will be coming outside the cell. So during depolarization, this sodium, it will be going outside the going inside the cardiac muscle. And when the threshold reaches the maximum, what happens is it starts repolarizing. Rather, when the voltage is given, there is contraction, and once the contraction reaches the limit, there will be relaxation of the muscles. And the importance of cardiac muscle is that there is a resting phase or plateau phase for the cardiac muscle. This cardiac muscles, our heart starts beating from the 4th week of our intrauterine life, and it stops beating on our death. So there is no rest for the cardiac muscle. But in case of skeletal muscle, what happens? Once we are working the skeletal muscles for longer time, it will go for weakness, or we will be getting fatigue. But in case of cardiac muscle, there is no fatigue because of the presence of calcium ions. So what happens is once the sodium ions enter inside and the potassium ions leaves outside the cell, slow gated, that is slowly moving calcium ions will be coming from the extracellular fluid towards the intracellular fluid. So this calcium will be coming towards the intracellular fluid. So what happens? This calcium ions, they are slowly moving ions, or there are slow channels or slow gateways for the movement of the calcium channel. So what happens? This although the heart starts relaxing, this relaxation will be in a plateau phase. It will not relax suddenly. So there will be a plateau phase, or relaxation will be in a plateau phase. So what happens? This cardiac muscle will get rest during this phase, and this cardiac muscle will not go for fatigue. So this is the importance of ions as far as cardiac muscle is concerned. And since there is hypercalcemia in parathyroid or thyroid disorders, there is changes in the ECG, or there is changes in the rhythm of the heart. So this is very, very important. The rest of the cardiac muscle during each cardiac cycle is due to the slow movement of the calcium ions. So calcium ions will be moving slowly, and the relaxation continues. And what happens is the calcium channels close at one phase. So what happens? This calcium influx will be reduced, and the cardiac muscle will go for relaxation. So in cardiac muscle, there is a resting phase or there is a plateau phase which prevents the cardiac muscle from fatigue. I hope you understand. So this slide explains the difference between the skeletal muscle and the cardiac muscle. So in skeletal muscle, you see there is a depolarization, and suddenly there is repolarization. But in cardiac muscle, there is depolarization. There is a plateau phase because of the influx of the slow influx of the calcium ions, and there is a resting phase. That is, there is a repolarization. So this is the difference between the skeletal muscle and the cardiac muscle. And this skeletal muscle goes for fatigue because of this property. Because of this what property? That is, there is no calcium. There is calcium influx, but it is not slow channel. But in case of cardiac muscle, the calcium influx is very slow. The calcium gate will be opening very slow, and so that this cardiac muscle have rest and it will not go for fatigue. Next is regarding the electrodes and leads in a ECG. So electrodes and leads. So there is difference between electrodes and leads in ECG. So we will be prescribing, when we are prescribing for a ECG, or when we are asking the patient to take ECG, we will be writing that standard 12 lead ECG, standard 12 lead ECG. So what is the difference between the electrode and the leads? As far as the electrode is concerned, these electrodes are the things which are placed in the surface of the body to record the electrical activity of the heart. And the recorded electrical activity by the electrode is known as the lead. So the difference is that what we are placing on the surface of the body of the patient is the electrode, and what we are seeing in the ECG or ECG graph is known as lead. I hope you understand the difference. Electrode and leads are not the same. Electrode is the one which is placed on the surface of the body in order to get the lead. Lead is the recorded electrical activity by the electrode. So what we are seeing in ECG is the lead, and it is not the electrode. What we are seeing in the ECG machine is the electrode, and what we are seeing in the graph is the lead. So electrodes. So now we are talking about the electrodes, and after this slide, we will not be talking about the electrodes, we'll be talking about the leads. So electrodes, there are 10 electrodes in a standard 12 lead ECG. So 12 leads are 12, but electrodes are 10. And what we are talking from here is about the 12 lead ECG. There are so many types of ECG, and there are 12 lead ECG, 24 lead ECG, 48 lead ECG. But what we are using in our daily practice is 12 lead ECG, and we were talking about the standard 12 lead ECG hereafter. So while reading all the things, or while seeing all the things, we should think that this is about the 12 lead ECG. In 48 lead ECG, 3 lead ECG and all, it is different. So we all know that the father of ECG is Reindoven, and he found out 3 lead ECG in 1901. And in 1954, American Heart Association standardized this 12-lead ECG. So the father of ECG, Eindhoven, found out 3-lead ECG, and it is a very big machine, and it is working with the help of galvanometer. But now it is very portable. And the first ECG was recorded from the heart of a frog. It is not from human. It is from the heart of the frog in 1842. 1842. So regarding the electrodes, there are 10 electrodes in a standard 12-lead ECG, and there are two types of electrode, that is limb electrode and chest electrode. So limb electrode are the electrodes which are placed in the extremities. So RA, the limb electrode RA is placed in the right arm. Limb electrode RL, it is placed in the right leg. Limb electrode LA, it is placed in the left arm. And limb electrode LL, it is placed in the left leg. So it is placed in the left leg. So these are the 4 limb electrodes. And chest electrodes, there are 6 chest electrodes named from V1 to V6. So these are the 10 electrodes which is used in a standard 12-lead ECG. And regarding the RL, that is the electrode which is placed in the right leg, it is the neutral electrode, and it will not produce any lead. It is the neutral electrode. Since it is the electrical conductivity, there is a neutral electrode which is placed in the right leg, and it has no other function, or it is a neutral electrode and it will not get the lead. And chest electrode, that is V1 to V6. Then about the leads. So electrodes, we understood that in a standard 12-lead ECG, there are 10 electrodes, and in a 12-lead ECG, there are 12 leads. Now we are going to talk about the leads. So regarding the limb leads, there are 2 types of limb leads: unipolar limb leads and bipolar limb leads. Unipolar limb leads and bipolar limb leads. Unipolar limb leads are represented as AVR, AVL, and AVF. AVR, AVL, AVF. So here only 3 leads, but in case of electrodes, there are 4 limb leads. I told that RL, the electrode which is placed in the right leg, it is a neutral electrode and it will not produce lead. But and it is absent in the unipolar limb leads. The unipolar limb leads are AVR, AVL, and AVF. So A stands for augmented, the word augmented. V stands for unipolar, and RL stands for site of connection. So as far as AVR is concerned, AVR, it is situated in the right arm. AVL, it is situated in the left arm. AVF, it is situated in the left foot. And this leads represent these 3 limbs. Next is bipolar limb leads. There are 3 bipolar limb leads, 1, 2, and 3. We'll be explaining in detail 1, 2, and 3. And chest leads B1 to B6. So what is unipolar limb leads? This unipolar limb leads, the positive lead or the positive side of the lead will be in the electrode which is placed in the extremity, and the negative electrode. So the electrode consists of 2 parts, a positive part and a negative part. This positive part will be the electrode, and negative part will be the electrical activity produced by the ECG machine. That is known as unipolar limb leads. There will be only one lead, there will be only one part, that is positive part which represents the electrode, and negative part which represents the ECG machine. But in case of bipolar limb leads, there are 2 poles, that is positive pole and negative pole. Positive pole and negative pole. So both the electrodes, here the electrodes will be representing the positive and the negative side. But in case of unipolar limb leads, the electrode represents only the positive part. I think you understand the difference. Then chest leads V1 to V6. So these are the leads as far as ECG is concerned. So we'll be talking about the bipolar limb leads in detail. So these are the position of the electrodes. That is right RA, it is placed in the right arm. LA, it is placed in the left arm. RL, it is placed in the right lower extremity, and LL, it is placed in the left lower extremity. And regarding the position of the chest leads, V1, it is very, very easy. So we know about the surface anatomy of the heart. So V1, it is placed in the right fourth costal cartilage. V1, it is placed in the right fourth costal cartilage, which is just near to the margin of the sternum. V1, first chest electrode, V1, it is placed in the right fourth costal cartilage, which is just near to the margin of the sternum. And V2, V2 is the second chest electrode. It is placed in the left fourth costal cartilage, just below the left fourth costal, or left intercostal space. You can say that intercostal space, which is just near to the left margin of the sternum. And next we are talking about V4. V4, not V3, V4. V4, it is placed in the fifth left intercostal space in the mid-clavicular line. V4 in the fifth left intercostal space in the mid-clavicular line. And the space between the V2 and V4, we are placing V3. V3. So V2, it is in the right fourth costal intercostal space, just near to the sternum. V4, it is in the fifth left intercostal space in the mid-clavicular line. V3 is in between V2 and V4. Then V5, it is in the left fifth intercostal space in the anterior axillary line. And V6, it is in the left fifth intercostal space, which is in the mid-axillary line. So I repeat, regarding the chest leads, V1, it is in the right fourth intercostal space, just near to the margin of the sternum. V2, it is in the left fourth intercostal space, just near to the margin of the sternum. V4, it is in the fifth left intercostal space in the mid-clavicular line. V3, it is placed in between V2 and V4. V5, fifth left intercostal space in the anterior axillary line. V6, left fifth intercostal space in the mid-axillary line. So these are the position of the electrodes. Chest electrode and also limb electrodes. 10 electrodes are placed. RA, LA, RL, LL, and V1 to V6. So this is regarding the bipolar limb lead. So we have already said that this bipolar limb lead, the positive side and negative side is in the electrode. But in case of unipolar electrode, the positive side is in the electrode and the negative pole is in the ECG machine. So lead 1, bipolar lead 1. It connects this RA with LA. That is the electrode in the right atrium and the electrode in the left arm. Right arm and the left arm. So this lead 1 connects the electrodes between the right arm and the left arm. Lead 2, it connects the electrodes between the right arm and the left leg. Lead 2 connects the electrode between the right arm and left leg. And lead 3, it connects the electrode between the left arm and left leg. So these are the connections of bipolar limb leads. And there is a rule as far as the ECG is concerned. When anything is connecting from up to down or downwards to upwards, the positive pole will be in the lower part. This is very, very important. So when there is a connection from above downwards or from below upwards, the positive pole will be in the lower side. This is the first rule. And second rule is when there is a connection between the right to left or left to right, the positive side will be in the left side. Positive pole will be in the left side. So we will see. We know that this first bipolar limb lead, lead 1, it connects right arm and the left arm. So the connection is between the right to left, left to right. So what happens? The positive side will be in the left side and negative side will be in the right side. So if there is any doubt, you may please stop and ask. So the lead bipolar limb lead one connects between the right arm and the left arm. So the positive pole is in the left side. Positive pole of bipolar limb lead one is in the left arm, left side, left arm. And then lead 2, it connects the right arm with the left leg, right arm with the left leg. So what happens here? First rule is applicable. The first rule is above downwards or below upwards, the lower side will be positive. So it connects right arm with the left leg. So the positive pole is in left leg and negative pole is in the right arm. You got the point. And lead 3. Lead 3, it connects left arm with the left leg. Left arm with the left leg. Again, the first rule applies here. Above, downward. So, above, downward. So, the positive pole is in the left leg. Left leg. Any doubts in this? Shall I continue? Sir?
Yeah, if anybody is having any doubt, they can raise it.
Yes, continue.
Okay. So, right arm, left arm, right arm, left leg, left arm, left leg. The rule is, this is very, very important. The rule is when there is above downwards or below upwards, the positive pole will be downwards. Positive pole will be down, and left to right or right to left, the positive pole will be in the left side. So this is the rule. And this is very, very important when we see about the ECG, because when there is change in this pole, or when there is any change in the cardiac activity, or when there is any infarction in the cardiac muscle, this changes and the ECG waves will get changed. Okay. This is about the how which leads is in connection with which part of the heart. Which leads is in connection with the which part of the heart. So lead AVF, it is in the AVF, the electrode is in the left foot. Lead 2, the positive pole is downwards, and lead 3, the positive pole is downwards. So what happens? This travels from positive towards the negative pole, and this lead 3, AVF, and lead 2, lead 3, lead AVF, and lead 2. It will be seeing the inferior surface of the heart. I hope you understand. From the positive, it will be seeing upwards. So what happens? This lead 3, AVF, and lead 2, it sees the inferior surface of the heart. We know about the inferior surface of the heart. We know about the inferior border of the heart. Inferior surface, it is known as the acute border. Inferior surface, it is formed mostly by the left ventricle and the right ventricle. Inferior surface is also like that. So this lead 3, AVF, and lead 2, if there is any change in all these 3 leads, or 2 of these 3 leads, the inferior surface of the heart is affected. There is some change in the inferior surface of the heart. The interpretation is like that. I hope you understand. Lead 3, lead AVF, and lead 2, the positive pole is downwards and the lead will be seeing upwards. So it sees the inferior surface of the heart. And lead AVL and lead 1. Lead AVL and lead 1. So lead AVL, the positive pole is in the left side. Lead 1, the positive pole is in the left side. So it sees the left lateral surface of the heart. Left lateral surface of the heart. So left lateral surface, we all know that it is formed by left ventricle. Left lateral surface or left pulmonary surface. Pulmonary surface of the heart. It is formed by the left ventricle. So lead AVL and lead 1 is concerned with the left ventricle. So when there is any change in lead AVL or lead 1, there is something happening in the left ventricle, in the cardiac muscle or myocardium of the left ventricle. Next, lead AVR. Lead AVR. So this lead AVR, it is placed in the right arm and the positive pole is in the right arm. So this lead AVR, it sees the cavity of the left atrium. Cavity of the left atrium. So left atrium forms the base of the heart. So this lead AVR, it is concerned with the cavity of the left atrium. So when there is any change in lead area, there is some problem within the left atrium. So that is the interpretation. This is the importance of this positive pole and negative pole. And regarding the chest leads. chest leads. V1, it is placed in the right side, just lateral to the sternum. V2, it is placed in the left side, just lateral to the sternum. So this V1 and V2, it sees the right ventricle, and V2 and V1 and V2, it sees the right ventricle. V3 and V4. This V3 and V4, it is concerned with the interventricular septum. The septum which is in between the right ventricle and left ventricle. And V5 and V6, what happens? It is towards the anterior axillary line and mid axillary line. That is towards the left ventricle or towards the apex. So it is the anterior and lateral wall of left ventricle. So this is very, very important. While we are interpreting the ECG, waves, when there is change in any of these ways, we can directly say that the part before, without taking echocardiogram, we can say that this part of the heart is affected since there is change in this lead. So this is the importance of this leads. So lead 2, 3 and AVF, it sees the inferior surface of the heart. Lead 1 and AVL, it sees the left lateral surface. V1 and V2 right ventricle, V3 and V4 interventricular septum, V5 and V6 anterior and lateral wall of the left ventricle, AVR cavity of left atrium. So all the surface of the heart is seen. Then regarding the ECG paper. So till now, I hope that you understand. Then regarding the ECG paper. So ECG, we all know that we are plotting ECG in a graph paper. It is a graphical representation. So the lead on the electrical activity, which is produced by the electrode, which is placed in the surface of the body, produces some graphical representation, and this is plotted in a graph paper and it is known as ECG. So as this is a graph paper, there is a x-axis and y-axis in an ECG paper. This x-axis represents the time. X-axis represents the time and y-axis represents the voltage of the ECG. X-axis represents the time and y-axis of the ECG represents the voltage. So hereafter we will be talking that this P wave. When we are explaining about the wave, we will be talking about the time of the P wave or the height of the P wave or voltage of the P wave should be like this, or the time of the P wave or time of the QRS complex should be like this. When there is increase in size or decrease in size, or when there is increase in length or decrease in length, there is problem. There is some problem with the conduction. Like that we will see. So this is the importance of the ECG paper. So ECG paper, there are large squares in the ECG paper, and in each large square there are 5 small squares. 5 small squares, total there is 25 rows and columns, 5 rows and 5 columns in a large column of a ECG paper, such that there will be 25 small squares in a large square. So now the each small square is of 1 millimeter. Each small square is of 1 millimeter in length, 1 millimeter in length and also 1 millimeter in breadth. That is, time is also 1 millimeter and the length, voltage is also 1 millimeter. So what happens is this 1 millimeter, we will say that this ECG paper moves at a rate of 25 millimeter per second.
Sorry to interrupt. Will be, I think this will automatically end and you please reconnect again. All are requested to reconnect once it is ended. Okay, please.
Okay, sir.
Proceed.
Okay. So x-axis represents the time. So in the ECG machine, what happens is this ECG paper travels at a speed of 25 millimeter per second. So in 1 second, 25 millimeter will be covered. That is, 25 small squares will be covered, which is equal to 5 large squares. Each large square consists of 25 small squares. But when we are counting like that, there will be 5 small squares in a row. So 25 millimeter per second it will be covering, and it covers 25 small squares. That is, it covers 5 large squares in 1 second. By calculating like that, it covers So time taken for covering one large square. So time taken for covering 5 large square is 25 seconds. Sorry, 1 second. 1 second. So the time taken for covering one large square is 0.2 second. 0.2 second. And the time taken for covering one small square is 0.04 second. We are dividing that. And we are calculating as the time for 5 large square is 1 second. The time for one large square is 0.2 second. So one large square has 5 small squares. So the time taken for one small square is 0.04 second. And regarding the height, 1 millimeter